This presentation provides information for patients undergoing gallbladder surgery due to gallbladder disease. To give you an overview, gallbladder disease is one of the most common diseases in the United States. Each year there are approximately 700,000 new cases of gallbladder disease, and many of these cases actually require surgical intervention to fix the problem. And the most common procedure done is a laparoscopic cholecystectomy. The overview of this presentation will cover the anatomy of the gallbladder, the function of the gallbladder, the symptoms of gallbladder disease, the pathology, or what's actually going wrong with the gallbladder disease, and surgical treatment options. So to begin with the anatomy, the basic anatomy of the gallbladder is located underneath the liver and in the right upper quadrant of the abdomen. That's why patients with gallbladder disease typically have problems in the right upper quadrant, and they can also have referred pain to the right shoulder given its location. As you can see, the gallbladder is not only involved in the common hepatic duct, but also has a pancreatic involvement. Therefore, patients with gallbladder disease can sometimes have pancreatitis. To talk more about the gallbladder, the function of the gallbladder is to concentrate and store bile. The bile is secreted by the liver and contains elements of cholesterol, phospholipids, and bile pigments. Bile then leaves the liver and enters the hepatic ducts, which then forms the common hepatic duct and the cystic duct join to form the common bile duct. The common bile duct empties into the upper part of the small intestines with the opening of the sphincter of Oddi. Normally the sphincter is closed and causes bile to back up into the cystic duct and furthermore into the actual gallbladder. This causes the gallbladder to fill and store bile. When the stomach is full or when a person eats actually fatty food, chemical signals are actually released from the stomach that causes contraction of the gallbladder and relaxation of the sphincter of Oddi. This allows the stored bile in the gallbladder to enter the small intestines and aids in breaking down food. To go back over this, I've mentioned most of the function of the gallbladder. So pause the video and look at this and go through the steps again if you'd like more information. People with gallbladder disease typically have these symptoms. As mentioned previously, they have pain in the right upper quadrant. Pain typically occurs within minutes after a meal. They can have actually a change in stool color. They can also have jaundice or yellowing of the skin or eyes if there's an obstruction of the common bile duct, as well as symptoms of nausea and vomiting. There are typically 5 different gallbladder diseases. They're listed right here, and I'll go through them. Cholelithiasis, or in other words, you actually have stones in the gallbladder that don't allow the bile to leave the gallbladder because it's obstructive. You can have choledocholithiasis, which is a stone in the common bile duct. This typically leads to the jaundice, as previously mentioned. You can have biliary dyskinesia, which is abnormal contraction of the gallbladder, and therefore the gallbladder doesn't typically empty after a full meal or after the fatty food chemicals that are released from the stomach, and therefore gallbladder sludge develops and it causes typical problems. You can also have cholecystitis, which is not with a stone, which could possibly be with a stone, but it's inflammation in the gallbladder. And finally, you could have gallbladder cancer, which is very, very rare, but still needs to be mentioned. So, where do gallstones come from? As mentioned previously, bile is made of cholesterol, phospholipids, as well as bile pigments. Gallstones come from the cholesterol that's typically insoluble becomes actually soluble and forms crystals with the phospholipids in the gallbladder. If the ratio of cholesterol, phospholipids, and bile salts are altered, these cholesterol crystals may also form. Typical risk factors for patients developing gallstones are typically females, typically patients that are overweight, as well as patients in their 40s and 50s, so older individuals, as well as women who are fertile or in pre-menopause. So if you believe you have gallbladder disease, how does your doctor typically work it up? Typically they can start with some blood test. This amylase and lipase is specifically looking for patients that have pancreatitis. They can also check a bilirubin level, and this will help them know if there's an obstruction in the common bile duct. They can get a complete blood count to look for infection, as well as liver function enzyme test to know if there's any function of the common bile duct, to know if there's a liver involvement. They typically also get an ultrasound, an abdominal ultrasound of the right upper quadrant to look for stones in the gallbladder, as well as an abdominal CT sometimes is warranted. They can even go do a gallbladder radionucleotide scan, or in other words, a HIDA scan that actually shows how the gallbladder is emptying or if it is filling. And this helps determine if there's biliary dyskinesia or stone blocking the gallbladder. So after you have gallbladder disease, what are the typical treatment options? First and foremost, you could do nothing. Symptoms may get better on the time, but more likely than not, you'll actually require surgery at some point to remove the gallbladder. The most common procedure is already listed as a laparoscopic cholecystectomy, which is also known as removal of the gallbladder using tiny scopes. As mentioned, this is one of the most previous procedures done by a general surgeon, and approximately 700,000 a year. There's also a chance that you could undergo an open cholecystectomy, which is rarely done. It's a longer incision actually directed right at the gallbladder, and they actually open up rather than use the cameras. To talk more about the most common laparoscopic cholecystectomy, below is kind of a brief description of the procedure. So under general anesthesia, 4 incisions will be made for the port placements. You'll have 3 5mm incisions and 1 10mm incision. The larger incision is actually located for the camera and removing the gallbladder. Carbon dioxide is then pumped into the belly to allow for better visualization of the gallbladder. The gallbladder is then retracted off the liver, and the cystic duct is exposed, clamped, and excised. Next, the cystic artery is then exposed, clamped, and excised. This allows the gallbladder to be freed from the liver and removed from the body. The liver is then irrigated with saline, and the carbon dioxide and excess fluids are then removed, and the incision site is closed. Typically, patients are then placed in an abdominal binder, and from there they go to PACU. These are the typical incision sites that are made for gallbladder. Granted that they can change versus your anatomy, as well as if there's any other problems. And as mentioned previously, there could be a possibility that you could have an open cholecystectomy. Typical frequently asked questions by patients are, do I have to stay in the hospital or go home? For routine gallbladder surgery, granted that there's no complications, typically patients go home the same day. They typically ask, how long does the procedure last? Typically the operating time is between 30 to 45 minutes. Once again, this is based off of without complications or without everything going smoothly. Anesthesia typically to get you anesthetized as well as to wake you up takes 35 minutes, and that means total OR time is an hour to hour and a half. Typically patients recover in the PACU between 1 to 2 hours, so therefore giving a total time between 3 to 4 hours, however it can be longer. Patients typically wear the binder for about 2 weeks. The incision sites that patients see, the 4 incision sites, typically become soft within 3 to 6 months, and the actual scar will fade within a year. Postoperative pain can actually be relieved by over-the-counter pain medications and some narcotics, just depending on physician and surgeon what they decide. Patients can typically resume normal activities within 24 hours, and heavy lifting should be avoided for the first 2 weeks. Thank you for your time during this presentation, and if you have any more questions, please feel free to ask your surgeon. These are the resources listed below.